from the American Academy of Pediatrics.
Pediatrics centers on treating children, but sometimes that extends to the entire family.
A new policy statement looks at providing medical care for parents during the pediatric visit.
When we are doing diagnosis or treatment, that is a physician-patient encounter. And so we need to treat that as we would treat any other physician-patient encounter.
But first, it's February, and that means it's time for a new First Up.
We know that mindfulness can decrease stress, it can reduce anxiety, depression, it can improve insomnia. So can it reduce substance use in adolescents?
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a research roundup from the journal Pediatrics. Joanna, how do you feel about February?
Well, when I was growing up, we always had a week off for President's Week, and my kids don't have that. They have 2 days off, one for President's Day and one for the Lunar New Year, but I wish we had a bit more time to travel and just get out of the cold.
Okay, that makes sense. I'm not sure I love February, but I love our collective response to it. Here, have some chocolate. No, I know it's cold and it's dark and you're tired of winter, but open this, try one. It'll still be cold and dark, but at least you will have had some fondant.
Well, I can think of another February treat. It's time for First Up Research Roundup, where we get to hear about exciting new research from the blog's editor of Pediatrics, Dr. Rachel Moon. And like a box of chocolates, you never know what you're going to get.
And that's all I have to say about that. Rachel, welcome. How do you cope with February?
Well, looking forward to March and April, I think. Yeah. February is hard, as we all know, because, it's been winter for a while. And you get these little sneak peeks that spring is coming, but nothing that's lasting yet.
At the time of this recording, we're not sure what the groundhog is doing.
Yeah, well, we're still dealing with literal mountains of snow.
Wow.
In Charlottesville. I'm not going to go into how they deal with snow. It's a very interesting process.
I'm sure Virginians are not the best with snow.
No, they're not. And as somebody who has always grown up in places that are more snowy, it's just very amusing to me how people that don't have equipment have to deal with it. And so when they get mountains of snow,
yeah, the citizens don't even know how to go outside, which is always funny to watch because I've been in California. But let's focus and let's give some good information from Pediatrics to help people cope with this winter. So, Rachel, I understand you have some news that we can use in neonatal ICUs. We always want our patients' families to be involved in their care and at the bedside, but few people have the ability to be there for days or months, especially when they come from far away. Could technology help us here?
I love that question, Joanna, because it really does put a burden on parents when children are in the hospital for an extended period of time, because the parents are trying to take care of their children in the hospital. They may have other children at home. Many of them have to keep working. And so when they're not physically in the hospital, they lose out on the opportunity to engage with the medical care team, to ask questions, participate in shared decision making. So this month, we have an article by Dr. Jennifer Rosenthal and colleagues at the University of California, Davis, that looks specifically at families of infants in the NICU and the impact of including these parents in virtual family-centered rounds. So I hope that all of us are using family-centered rounds on our inpatient services, as this is really best practice for improving family engagement and really getting everyone, family and staff, all on the same page. This study was a cluster randomized controlled trial where they randomized families to either usual care, which was that you can attend rounds when you're in the hospital, but otherwise you don't, or an intervention where you could attend rounds in person when you were in the hospital and attend virtually when you are not in the hospital. So just before the team made rounds on your baby, you would get a text or an email link to join by live video conference. So what happened? I was amazed at this because parents in the intervention group, so the ones that were able to attend the virtual rounds, they attended rounds almost 5 times as often as those that got usual care. And when they looked at different subgroups like race, ethnicity, neighborhood, the only subgroup for whom there was no impact of the intervention were parents who either didn't have a smartphone or had low digital literacy. In particular, when they looked at families from neighborhoods with fewer resources, they found that families in the control group had lower attendance at rounds, but those in the intervention group did not. And then when they looked at longer-term impact, infants whose parents were in the intervention group had much lower odds of having an emergency department visit within 30 days after NICU discharge. So surprisingly, there was no positive impact on patient experience, and it's not clear why that is. But one obvious limitation to the study was that it only included families with at least one English-speaking parent. And we know from so many of our conversations on this podcast that we don't do a great job with communicating with these families who speak other languages. Nonetheless, this seems like the type of change that could be fairly easily done in most hospitals, and I think it would definitely be changed for the better in terms of including families in our rounds.
I'm especially impressed that just having a video visit can reduce ED use later on. I mean, that seems like a really compelling rationale. I want to turn to slightly older children now. One of the scariest calls I've gotten was when I learned our son had sustained a concussion and an occipital skull fracture playing foursquare, of all things. He's okay now at age 24, but at the time I was worried the effects would last a long time. Do we have any new insights into the lasting impact of head trauma?
David, that is an interesting question. And when we think about concussions, we usually think about our adolescent patients, particularly those who are athletes. And many of us feel pretty comfortable with that scenario, what factors might predispose to persistent symptoms, how to counsel these families, things like that. But then how about a child younger than 6 years old? Do you feel comfortable talking to parents about that child's concussion? And even though we don't think about it, concussion in this age group is very common. However, it happens most often not because of sports injuries, but because of falls. And because young children have big heads and small bodies, and because their neck muscles are not that strong yet, young children who have head injury are much more likely to sustain a brain injury. And their symptoms may not be what we think about when we think about concussion. So this month, we have an article by Dr. Sean Rose from National Children's Hospital and colleagues from the KOALA study, which stands for Kids' Outcomes and Long-Term Abilities After Early Childhood Concussion. And they looked at the prevalence of persistent symptoms after early childhood concussions and what factors might predict these persistent symptoms. So they enrolled children 6 months to 6 years of age who presented to 4 tertiary urban pediatric emergency departments, 3 in Canada and 1 in the U.S. These children either had concussion or orthopedic injury. They also recruited non-injured controls from local child care centers and community groups in Canada. To be in the concussion group, you had to have non-penetrating head injury in the last 48 hours, a Glasgow Coma scale of 13 to 15, and at least one of the following: a palpable skull fracture, headache, altered mental status, or loss of consciousness. To be in the orthopedic injury group, you had to have limb trauma in the last 48 hours with a diagnosis of a fracture, sprain, contusion, or unspecified trauma, and then no evidence of traumatic brain injury. Parents then completed a reactions symptom checklist, which is a developmentally appropriate measure of 17 concussion symptoms in young children. It includes concentration, memory, headache, nausea, balance, sensitivity to light and noise, irritability, regression, comfort seeking, things like that. And the children were also assessed in person at 10 days, 1 month, and 3 months after the injury. And the parents completed this symptom checklist at all of these points and then at 12 months. There were a total of 418 children in this study. 235 had concussion, 108 had orthopedic injury, and 75 were controls. The median age was 2.8 years and half were male. In the children who had concussion, there was a high prevalence of persistent symptoms. 28% at 1 month, and 16% at 12 months. And then as with older children, those younger children who had higher scores on this checklist at the time of presentation to the emergency department were more likely to have persistent symptoms. So now what do we make of these findings? We asked doctors Hannah Heinz, Robert Hickey, and Danny Thomas at Medical College of Wisconsin and the University of Pittsburgh for a commentary. So while we have not generally followed young children after concussion because we depend upon neuronal plasticity to fix everything, they point out that this study shows that that may not be true. We do need to follow these children. They may need developmentally tailored follow-up and support. This study, I think, demonstrates that there's still much more that we need to learn about concussion in young children. I'm sure that this is not the last study that we've seen on this topic.
And now I'm not sure I can let my kids out of the house without a helmet. Thank you for that, Rachel.
Sorry.
Let's talk about using our heads a little differently. Adolescent substance use disorder seems challenging to treat. So it's a relief to imagine that an intervention as accessible as mindfulness might help. It seems almost too good to be true. Is it?
Well, I thought the same thing, Joanna. And then I read the article and I was quite impressed. So Joanna and David, to start with, do you know what substances are the most commonly used by U.S. 12th graders?
Alcohol and tobacco?
Correct. Ding, 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 ding. So alcohol, almost half have used it in the past year and 22% in the last 30 days. Any type of nicotine, about 34% have used it in the past year. And then number 3 is cannabis, any type of cannabis. And that's 26% of all U.S. 12th graders. So we have psychosocial interventions such as cognitive behavioral therapy that are considered first-line strategies for treating substance use in adolescents. But these interventions are often very difficult for many to access, and the effect is very small and generally not long-lasting. There's been an increased interest in mindfulness-based interventions for adolescent substance use and substance use disorder. So I want to remind people what mindfulness is, and it is, I quote, the awareness that emerges through paying attention on purpose in the present moment non-judgmentally to the unfolding of moment-to-moment experience. So basically, you want to be aware of what's happening and not place judgment or blame or anything about it and not react. So we know that mindfulness can decrease stress, it can reduce anxiety, depression, it can improve insomnia. So can it reduce substance use in adolescents? Maybe you could use mindfulness to think about the craving or the distress that usually leads you to substance use with more awareness, less judgment, so that you don't react immediately to the situation by using drugs or alcohol. So that's the idea. So this month, we have a systematic review by Christopher Hammond, MD, Lindsay Webb, PhD, and colleagues at Hopkins, Albert Einstein College of Medicine, Baylor College of Medicine, and the University of South Dakota that looks at the efficacy of these mindfulness-based interventions for substance use and substance use disorder in adolescents. The authors included 23 studies with nearly 2,300 participants, and they included all kinds of interventions. So the specifics of the interventions differed from study to study, but the most common interventions that were looked at were mindful breathing, urge surfing, when one observes an urge without acting upon it, and then mindful meditation that was combined with other therapies such as counseling. And their findings were intriguing. 2/3 of the studies found positive impacts of mindfulness-based interventions, including reductions in substance use when compared with other treatments. And these mindfulness-based interventions, this was associated with decreased negative feelings and improvements in self-efficacy. So you felt like you had more control over the situation, improvements in impulse control, and improved ability to handle stress and fight cravings. So there are some caveats here. So some of the studies have small sample sizes. And since the outcome measures were different, it's hard to make clear conclusions. Additionally, I would assume that these kind of interventions are most effective in those who are insightful and motivated to reduce their substance use. However, I think mindfulness may be an additional tool that we can use in our toolkit that could be helpful for some of our patients.
Well, Rachel, I certainly hope that's the case, and that's pretty encouraging. To take us through this short month, maybe this is going to require some urge surfing on your part, but what's your favorite kind of chocolate?
Dark chocolate, definitely dark chocolate.
David, what's yours?
I'm right there with Rachel. I mean, the dark chocolate, the darker the better.
Yeah, white chocolate doesn't do it.
No,
No,
is
white
that?
chocolate's not
That's
chocolate.
it's not
well,
chocolate.
okay, that's controversial. And we try not to be controversial on the podcast, but
Well,
it's
we
not
do.
that good.
Well, my personal opinion, I don't want to yuck anybody's yum, but I personally don't feel that it's worth the calories.
I mean, I agree
The
with
white
you.
chocolate lobby is coming for us.
I think so. I'm sure they
we're
are.
in trouble for sure. But I like a good caramel-filled center of a milk chocolate, and I could pick it out of a box. That's a skill that I have. But I can find that caramel. And I don't
If you
even
pick
need
it out
the
of my
guide,
box, you'll
you know?
find it's what's left.
Good, then we have to share.
It's
David.
easy. I'll send you all of my used chocolate boxes, and you can have all the caramels.
Nice. To read today's articles, join us at aap.org/podcast.
Coming up, we'll discuss providing medical care for parents during the pediatric visit.
When people say, I don't know how you care for babies, they don't really interact with you, I have two reactions. The first is to defend the interactions that babies do have with us as their brains grow at a phenomenal speed. The second is to talk about how I care for the whole family, and in particular, the birth parents or mothers, and I love that about my job.
I think many pediatricians would have that second reaction when they talk about caring for kids, that it's really about caring for the whole family, and particularly the parents.
So as a neonatologist, I give a lot of breastfeeding advice and counseling to new mothers and also to their partners when we talk about how important partner support is when it comes to breast milk production. I've not given vaccines to parents or anything like that, but I do feel like I'm counseling them a lot. Have you done any medical interventions for families, David?
You know, I have friends whose practices are set up to do that, but when I was an outpatient pediatrician, we never felt quite comfortable overcoming the barriers with charting, billing, and malpractice. Remember, though, I'm med-ped, so I do feel comfortable caring for adults. For pediatricians who might not, there's a new policy statement called Providing Medical Care for Parents During the Pediatric Visit that I think might be really helpful.
And here to talk about the policy statement is Dr. Steven Bondi. Dr. Bondi is not just a doctor, he's also a lawyer. He works at the University of Rochester Medical Center as an associate professor and specializes in pediatric critical care. He is also the chair of the AAP Committee on Medical Liability and Risk Management. Dr. Bondi, welcome to the show.
Thanks for having me.
So, Steven, this is not one of our Pathways to Pediatrics episodes, but I am a little curious. What was your pathway from law to pediatrics?
Well, we don't have time for the full story, but I'll give you the abridged version. I went straight through from high school to college to law school, and then was a practicing attorney for 7 years, and really was looking to do something a little bit more direct, involved with people and positive impacts. And that's how I got back on the right track, I would say, to go to medical school. And then I thought I was going to be an orthopedic surgeon actually at first, but got very interested in pediatrics and particularly critical care in medical school. And that's how I got to where I am today.
Well, since you have the expertise to answer this question, let's start with the big one. Can a pediatrician medically treat a parent? Is that within the scope of our practice?
Well, can is an interesting verb in that situation. It really is a question more than just can. It's may we, are we allowed to? And is it a good idea? So when we talk about can we, we're usually talking about licensure. And licenses tend to be unrestricted, issued by a state where most states were licensed to practice in medicine and surgery. Nobody wants me to practice surgery on anybody, I assure you. But what limits our practice is a variety of things. One is our credentials by whoever we work for. But if we're independent, we may not be credentialed by an institution, but we would be credentialed by insurance companies. And so they may dictate what the scope of our practice in terms of payment is going to be. The other area that we have to think about is what's within our scope of practice is who's covering us for malpractice in case something goes wrong. And in that situation, we need to look to whether we're an employed physician. I'm an employed physician. Would my institution consider a given practice type within my scope of practice? Or if we aren't covered by an institution, would our insurance carrier cover us for that particular thing?
And, I gave an example earlier of giving breastfeeding support and advice to patients as a neonatologist. Am I right in considering that kind of education as sort of a treatment of them?
I think there's a line there, and I'm sure that we're going to probe that pretty good. I think that as pediatricians, as you said in the introduction, we kind of look at our patients not as separate entities. We look at them as part of a larger system, and parents are more than just a support structure for children. So some of that advice, is it actionable medical advice, or is it just kind of, this is what we need to advise you just to help the child? And I think that's where we should start to think about where that line is.
Well, my wife works in mental health, and I've learned a lot from her and her practice. I will give advice on resources to families when I'm worried they may have a mental health issue. Would that be crossing a line as a pediatric hospitalist?
I wouldn't consider that crossing a line. I think that is standard things that we would all do, whether or not we are a medical provider, frankly, and certainly not necessarily a clinician. Nurses do that, social workers do that, friends do that. So I don't think that's a particularly concerning practice.
There was this one situation I had with my pediatrician. It was the winter of 2024. I got the flu while caring for my 6-week-old infant, and I panicked because I've cared for babies with the flu in the NICU. My pediatrician, through a Zoom call, because my husband brought the baby into the office, sensed my panic and gave my whole family, including my 2 other kids, prophylactic Tamiflu. And I was so grateful for this. Was this just above and beyond, or is this something pediatricians should be considering?
Well, I'm not going to really comment on the decision to give prophylactic, antiviral therapy, because that's beyond the scope of what I do. But I will say that I would consider that episode delivering medical care to other people. Now, let's take a step back and think about this. There have been models for doing this for years. And I think, David, you may actually be able to give some insight on this, because we've been doing partner therapy for chlamydia treatment, for example, for years. I mean, I remember it wasn't new when I was in medical school, and that was 20 years ago. And that's giving medical care to someone who's not in front of you. And so if you prescribe a medication to someone in a way that is an indirect physician-patient relationship, we can't prescribe medications and then not expect to meet a certain standard when we do that. I think everything depends upon what we're doing and what the nature of that relationship is. So moving forward to the situation that you brought up, Joanna, certainly treating somebody other than the patient in front of you, or in this case, I consider a prophylactic intervention, a treatment, that is delivering medical care. And that raises a whole host of other questions, right?
And what are those questions that pediatricians should be considering?
Well, the first question I would ask myself is, what's the nature of the intervention? There are interventions that are very, very low risk. And I think that when the original framework for doing partner therapy, the thought was the treatment for chlamydia, the risks of it are so low. Typically, what we're using azithromycin, right? For, oral azithromycin. The risks are so low that in balance, this is an overall very good. And so that you have to balance those risks. Because when we start to get into proposing higher level interventions, or a situation is, I don't love the word risk, but it's got more chances of complications, or it's more serious, then I think we have to be thinking more of just kind of like doing something essentially that's blind, right? If we're prescribing azithromycin to a 15-year-old's partner for partner therapy, there are a lot of questions we're not asking of that partner, right? That we might ask if they were in front of us. And so we can talk about some of those other situations in a second. But I think that's the first question I would ask myself is, what am I proposing to do? Oseltamivir is a relatively safe medication if we were to order medications on low risk to high risk. And so most of us would feel fairly comfortable prescribing that medication without having much information about who's receiving it, especially in the situation that you were proposing, Joanna. So I think that that's one, is that there needs to be an internal risk assessment by the provider in terms of what am I doing, especially with these disconnected or these blind interactions and provisions of care. So that's number one. Then the second question is, how are we going to capture the fact that this happened in our medical record? And that presents an interesting conundrum for us that's kind of outside of medical liability law, but may move into issues with HIPAA, right? Because we really shouldn't be putting medical information about treatment for one patient in a different patient's medical record. So do we have a system to track the fact that we wrote this prescription? And if there was a decision-making process, and we'll talk about that more with some of our interactive episodes of care with moms and dads in the clinic, but do we have a way of capturing that in the medical record and keeping it appropriately private and separate from the child's record? And then the third thing is, and this is important, is in some situations there may be payment involved for what we're doing. And if that's the case, if we're delivering vaccines, one example, to adult patients, and there's a way we can get paid for that, we should get paid for that because we're delivering a valuable service and it costs us to deliver that service.
So in the newborn nursery, I would love to be able to ensure that every family member around a baby is protected from, say, whooping cough. Is there a way for me to make sure everybody gets that vaccine safely?
I think there are a couple of questions here. One is, if we're working within an institution, there may be options to get individuals immunized within an institution program. And I think a lot of places do that with flu. And I know that our hematology oncology group will do that with other vaccinations for family members for their patients as well. But we're talking about situations where institutions tend to have a lot more resources than somebody who's in a small practice, right? So yes, there are options to do that. And really what you're talking about is the same thought process you go about recommending a vaccine for a child. You're just going through that same process for an adult. So you have to be thinking about risk, benefits, and alternatives of the vaccine. You have to be thinking about, does my patient, and I'm going to use that word because when you're offering a medical treatment, you've established at least a brief patient-physician relationship. Does my new patient, mom, dad, or both in this situation, does that person have a contraindication of the vaccine? So it's something we're all comfortable doing. We're just used to doing it with children instead of their parents. So it's the same thought process for us as the clinician. But we also have to superimpose all those things we talked about earlier on that as well. Will I get paid for this? Does my malpractice cover this? Does my credentialing cover this if I'm in an environment where credentialing matters?
And I think all the scenarios we've talked about so far, Steven, don't involve life-threatening conditions for the parent. I'll use an example as a neonatologist again, which is postpartum depression and potential suicidality. If you have a patient that you're really worried about their parents in that situation, what recourse do you have as a pediatrician?
Yeah, I think this is a really important one because I think the movement for pediatricians to screen mothers, and I know now we're talking about screening fathers too, for postpartum depression is absolutely wonderful, and it's high impact. It's so important. What we have to do is we have to understand that once we've embarked into a diagnostic mission, even if it's for screening, we have a certain obligation to follow through with what those results are. Now, that doesn't mean that we're responsible for embarking on a course of psychotherapy and medication to treat the malady. If we discover that a parent in this case is struggling with depression, we have a certain threshold to try to get them steered in the right direction. That might be a referral in a severe case, or it may just be reflecting back on their primary provider or their OB provider in that situation and just simply picking up the call. And if it's severe, these are situations where we'd really want to close the loop. I don't know if sending an email I would be comfortable in my practice doing that. I want to make sure that I actually got a hold of that provider and had what I would say, communication. One of my safety mentors once said there's a difference between notification and communication. So we close that loop. So that would be one example of where we could, I won't say ensure because that assumes that we're going to have a certain outcome, but at least maximizes the chance that there will be follow-up and make sure that that person's longitudinal provider is taking care of them. So that might be one option. That person may not have that person, and then it may be steering them. It may just be making a strong recommendation. Hey, I can see that you're really, really in trouble right now. I mean, we've all seen this with children we've taken care of. I don't think you're in a safe environment. I would strongly recommend that you go to the emergency department. Now, one of the things that we are less comfortable with in pediatrics is that most of our patients are minors, so it gives us a little more leverage over them in terms of ensuring follow-up, in severe cases, contacting CPS. But with adults, we don't have that option. So it may just be, I'm really, really worried about you. I think that what you're telling me is a risk to yourself or your baby. I really think you need to see someone today. I think you should go to the emergency room and get checked out there so that they can hook you up sooner rather than later. And then you want to make sure you document that. And that may even include, in a severe case, if the patient's refusing what you're advising, to put that in a letter to them. And if it was really bad, I might even send that certified.
Well, Steven, we have heard so many great pieces of advice from you today, and it's been so informative. Can't you give us one last takeaway for how pediatricians can help treat the whole family?
Yeah, I think the most important thing, putting my attorney pediatrician hat on, is to remember that when we are doing diagnosis or treatment, that is a physician-patient encounter. And so we need to treat that as we would treat any other physician-patient encounter. So that includes assessing for appropriateness of whatever we're doing appropriate follow-up, and then making sure that we document that in order to have those records available both for the patient and for protection for a medical liability standpoint.
Dr. Steven Bondi, thank you so much for joining us today.
It was my pleasure.
To read the policy statement providing medical care for parents during the pediatric visit, go to our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Okay, mine is kind of weird, but we just moved to Seattle, and I just have to thank all the drivers of Seattle who have not run us over at crosswalks. Apparently that's a thing. There are signs that say every corner is a crosswalk. And of course, we walk the dogs twice a day. And man, you start walking out in the street with a couple of dogs, people get serious about stopping. And honestly, I have never lived anywhere that people cared that much, whether you were in the street. So there you go. It's a new culture, and I appreciate this part of it.
My Say has to do with my kids, and my son had his 100-day kind of art project that he had to bring into school. I don't know if your kids did this when they were really young. He's in kindergarten, so for the 100th day. And he's still got that sparkle of a little kid, and he wanted the whole thing to be dragon based with these little 100 scales that we put on the dragon with glitter and every color. The dragon is colored every color because he doesn't believe in coloring something just one color. It has to be every color. No. So it's just a very fun little art project to do with him. And I love the 100-day challenge things and what kids can come up with. So I'm really excited to see what his class does.
That is so cool. I wish I could see that. And hey, you've got one more coming up in the future. Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll hear a Pathways to Pediatrics from a pediatrician who has dedicated his career to health equity and advocacy.
We'll talk to Dr. Peter Asante. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.